when the patient gets admitted, which was really weird in this case because this patient was not admitted for anything related to mental illness. So there was no reason even for that ER doc or that ER nurse who admitted her that day to tell the floor, oh, by the way, she might hang herself while she's upstairs, because that was totally irrelevant to what they were caring for her for. But it was a different team on a different day who responded to the code blue. So we really struggled with how to manage that. At the same time, we were having problems with people coming in who exhibited very bad behavior in the emergency department, not necessarily drug-seeking behavior, but they were aggressive, or they were threatening, or they were disturbing the waiting room, or they were stealing things, or all kinds of bad behaviors that some small subset of individuals might choose to get into. And we wanted a way to start managing them, putting bumpers on their care, and setting some enforceable behavioral expectations. And in Houston, they were doing this thing called triage out, where a patient would come into the hospital and say they had an earache. And the emergency doctor would go look in their ear. Yes, you have an earache. An earache is not an emergency. If you'd like, I can send you somewhere that provides non-emergency care, or if you want to stay here, I'm going to need $700 cash from you right now for your earache. That's called triage out. And it was very popular in Houston for a while. It's since fallen by the wayside, but at that time we were getting a lot of pressure from our hospitals to figure out a way to triage out. And so I thought, I don't necessarily want to triage out, but I do want to control the behavior of people who are using the ER for primary care. The interval cost of caring for one patient with an earache is zero. The doctor's already there, the nurse is already there, the lights are already on. There's not a problem with somebody coming to the ER once for something. But when people are using the ER for primary care, we want to identify them and help them to find a better place to get care. And we think that'll be more successful as a business model in the long run than insulting a third of our patients by telling them they don't have an emergency, you made a mistake coming here, whatever. And by the way, we're going to charge you a screening fee when we don't treat you. Or you can pay us $700 cash if we do treat you, which is extortion, I think. And so it was really just not a good model. So thinking back to the significant event, I was working a night shift at Seton Northwest, and it was a slow night. It was like a Wednesday or something when nothing was going on. And so it was about 2 in the morning, and I had my team gathered around. And my unit clerk was there, and there was an IT guy who was there fixing my unit clerk's computer because something had gone wrong with it. And so I started this conversation with them about the significant event at Brackenridge. And I said, I know we don't work at BRAC, and so in a way it's not our problem, but the network administration has tasked emergency services with figuring out how to create push technology for our system so that we can push information to others who haven't even seen the patient yet. Let's brainstorm on how we might do that. So the nurses were throwing out ideas, and the techs were throwing out ideas. And then Kevin, our IT guy, looks up and he says, well, there's this field in our registration program that we never use. If your name was Thurston Howell III, we would put the third in that field. But we just record you as Thurston Howell, and we tell you from the first, second, and third based on your date of birth. And so we never populate the field that says the third, but it's in there. And it's in there as part of the name, and because it's in there as part of the name, if you were to choose to put something in there, it would print on their wristbands and their patient labels and anything else that prints. I call that a technology breakthrough. Invented by Kevin at 3 in the morning at Seton Northwest. So, that really is as complicated as all this gets. So then we developed a database because now we realized we had a way to push information forward, and now we had to have a way to organize the information that we wanted to push forward. So I did something that doctors don't do. I had IT come to my office and install Access on my office computer. And I got an Access book, and I've tried to figure out what I wanted a database to do, and I made the world's, pardon the language, but the word is just appropriate for how bad this was. This was the shittiest Access program ever. But it worked. And so then what we did, because it was only on my desk, is I'd have to actually print out the care plans every time, and then I had a coordinator who took them to all 8 Seton hospitals and put them in binders at the desk. But now the difference was now when the patient came in, something printed on their wristband told the staff to look at the database, which was actually in paper at the desk. And then gradually since then, once we proved the value of this, we got excitement from our administrators, and they actually gave me a real programmer, and we created a SQL database, and we put it on the intranet, and now anybody who's got a Seton username and password has read-only access to the database. It's become more advanced as things do. But really, I wanted to give you guys a concept of just how simple it was to get this started. And we were actually very successful with this in advance of making it easy with tools. So the way the process works is very simple, very straightforward. We get a patient referral, and I'm leaving that vague because it comes from anywhere. I once had a housekeeper tell me that she was in changing the trash, and she overheard the patient bragging to the companion about how they were going to get narcotics out of us, and she didn't think that was right, so she came and found me and told me I needed to do something. Sometimes we get it from private doctors. We got a deal right now with several of the health insurance companies that they send us a letter saying, your patient has had this many ER visits across the state. Are you aware of that? Or they've had this many narcotic prescriptions. Are you aware of that? Or whatever. We take referrals from anywhere. Intentionally open about where this comes from. We review that referral, and we go through the patient's chart, and we go through everything we can know about them. So there's a review process. And in fact, I'll even try to call their primary care physician if they have one. I try to call the patient themselves, talk to them about what's going on. Try to get as much information as I can to create a care plan that really is truly and sincerely special for that patient and appropriate. And then I create that care plan, and we implement it by putting something in that field and making sure that the patient is now marked for future encounters. The whole process is a little bit complicated because we have a lot of people involved. So we have case managers, social workers, the director of nursing, the medical director, administrators, great support from IT helping us to create that database, but we always wanted to keep the patient in the middle. And so in the way that we set this up, there were a lot of conversations about how to keep the patient in the middle. And also, there had been a reality for a long time that actually is against the law now, or at least against the rules. When I first started emergency medicine, we all had a little black box that held 3x5 recipe cards. And what would happen is the patient would get labeled as a problem. A tech would say, this guy's a jerk, and stick it in the 3x5 card holder. And after that, that always affected their care because you just believed whatever was written on that card, no matter who wrote it or how it got there. And once it was there, it was never coming out. And so the Joint Commission on Accreditation of Hospitals said that practice is illegal. We're not going to allow it anymore because it's prejudicing patients' care. And we can't allow that. So I was really worried that this was going to be seen as an electronic version of a black box. And so that's really part of why we really focused on the patient-centeredness of this, and we also put safeguards in place. So I mentioned that the staff at large have read-only access to the database. Medical directors and directors of nursing have the ability to write care plans and approve them for view by others. So there's stuff in the database that only medical directors and directors of nursing can see, and there's stuff in the database that everyone can see, and there are communication tools that we built into it that help us to manage it all. But that's really the point of it was to make sure that we were not just labeling a patient in a way that was inappropriate. Joint Commission came and looked at it, and the first time I was very, very nervous, but they said, this is good. The second time they came to look at it, they said, this is awesome. The third time they said, this is best practice. When they started using the word best practice, like that became a thing. And so we really, now between all of the acute care hospitals that we have this implemented, this has been reviewed by the Joint Commission probably close to 30 times. And they've not ever found an issue with it, so other than that they like it. So what we do, the question is, what do you put in that field to make it stand out? So, and we also were told in order to get it to print, there has to be something in that field for everyone. It can't be blank and then not blank. There was some IT thing that I didn't understand, but I believe them. So if you come to Seton today and you're a brand new patient, never been seen there before, you will see the number 4 print somewhere on your wristband. And that tells us that you are a normal person, don't have any special needs that we know of yet, and we're going to treat you the way we treat anybody who comes in with your chief complaint. If they're a level 3, that means they have some special care plan, and I'll get into examples of that. And what actually prints on the wristband is the number 33. We added an extra digit because we thought if everybody's just looking quickly, adding that other digit might catch the eye. If you're used to seeing one thing there and then suddenly it's bigger, you might notice it more. So we put a 33 there instead of just the number 3. But basically what that says is there's something unique about this person. Go to the database, see what it is. Level 2 would be the gal who started this all. Anybody who has actively tried to harm themselves while under our care is made a 2, and on their wristbands it prints 222. And then the 1111s, those are the patients who have been dangerous to others in our facility. If they brandished a weapon, they punched a nurse, they made terroristic threats, anybody who's actively been dangerous to others on our campus is a level 1 patient. And we have specific policy around the approach to each one of those. So some examples of cases. And I'm just going to pick a couple random off the list. I had this lady call me one day, 80-something years old, and she said, I heard you got this thing called High Alert and I want in. Okay. Are you an investor, or what exact, in what capacity are we talking about? And she said, I tell you, I'm 86 years old. I have been a fighter my whole life, but I'm sick, and I do have to come to the hospital fairly often. And it seems like every single time that I come in the hospital, y'all try to talk me into dying. See, there's a Joint Commission standard that says you have to ask about advance directives on every visit. Do you have a DNR? Do you have a living will? Are you sure you're 86 years old? Crying. You actually want us to do CPR on you? Are you insane? She said, is there anything you can do at all to get them to quit asking me that damn question? 8 months later, I love you. You're awesome. They made it much. So that's an example of what we can do with this. Sickle cell patients, another example. There are some sickle cell patients who respond very well to morphine, but not to Dilaudid. There are some people who respond very well to Dilaudid, but not morphine. There are some who don't respond to narcotics at all, and they need an adjunct. We can, for each individual, identify what works best for them and write a care plan that specifies the drug and the dose and the frequency and get it in their chart. Because there's this weird phenomenon that happens in emergency medicine. As soon as you tell me morphine 6 milligrams is the best thing for me with my condition, I say, you are a drug seeker. The last thing I'm going to do is give you 6 milligrams of morphine. You know the name of the drug and the dose, you know a little bit too much. So that's what happens psychologically to the emergency physician when that conversation happens. But when I put it in a care plan, morphine 6 milligrams, everybody says, oh, okay. That's the right thing. And those patients come in with their care plan in hand. Don't believe me? This is what Dr. Ziebell says you're going to do. So those are examples of things that we can do with it. So for those of you who work in the hospital setting, you just think about what your biggest challenges are and whether or not you could use a program like this to help you manage your challenges. Looking at developing boundaries of care, we had this guy who had a condition called cyclical vomiting syndrome. The Latin name for that is intestinal migrainosis. What that means is migraine headaches of the gut. Now, migraine headaches happen when blood vessels spasm, and then the brain says, I need more blood, and then they relax, and then that relaxation of the blood vessel drives blood into the head with such force that it causes the headache. That's why that throbbing, pounding headache of a migraine. But in the gut, brain has the ability to control things. Gut doesn't have the ability to control things. So in the gut, what happens is the blood vessels spasm, and they stay spasmed, and the gut starts to develop ischemia, which means inadequate blood flow, and it's remarkably painful. And the gut says, I can't process anything that's in me right now, and so the patients start throwing up like crazy. These people end up coming in the hospital a lot, some of them, and they also have this unique characteristic where because they come in the hospital, we start second guessing whether it's appropriate for them to be there, and there starts to be all these judgmental things. And then they come in and they don't know if they're going to get help or not this time. They don't know if today's the day that we're going to tell them, too bad, go away, you've been here too many times. So they actually start coming earlier before they're really in severe pain, because they know that they might get turned away without any treatment, so they want to, and then they're very aggressive. And so this one guy was coming in, and he would walk in the triage and stand in the lobby and start screaming before he even got to the nurse. Here I am again. I know y'all are going to take crappy care of me, and everybody in the waiting room is hearing this, but I don't have any choice. I got to be here. I know you're going to yell at me. Da, 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 da. Okay. So for this guy, I set up a case conference, and I got him, his mom, his dad in the room. I got his primary care physician in the room, the hospital administrator and the hospital medical director in the room, and this is my favorite part because I didn't even know this existed until I was trying to set up this meeting, but I got the nation's expert on cyclical vomiting syndrome out of the University of Missouri to conference in on the phone. And so we talked to this guy for about 45 minutes about what his needs were and had the expert to help guide us. And we wrote a care plan that we all would agree to. When you come in, this is exactly what we're going to do. We're going to do it every time. We're going to do it the same. The dose is never going to be higher. It's never going to be lower. It's always going to be this. We negotiated an agreement that he thought he could live with, that we thought was medically appropriate, put it all on the table. And he said, I like it. I think this is good. And then I kind of smiled a little bit inside, and I pulled out a piece of paper I'd already written, and I put it on the table, and I said, now here's what I need. I will not yell at the nurses. I will not cuss in the waiting room. I will not raise my voice. I will not da-da-da-da-da. We'd outlined what our behaviors were going to be, so I went ahead and outlined all the behaviors I expected out of him, and I made him sign it. And I said, now understand clearly, you're seeing that I have the power to pull this off. And I'm telling you, you violate your part of the contract, our part of the contract goes away. Heavenly. When I moved from Seat Northwest to Brackenridge, he followed me. Because he was that worried that his care plan might change in the absence of that. But it really, to see him come in and be peaceful and calm, and he was actually able to because he no longer had the anxiety or the insecurity about whether or not he was going to get treatment. And so those are just some examples of what we can do. What does it take to implement? I've got a policy I can show you. But basically it's fairly easy as I've described. Development of a little, very simple database that an inexperienced doctor can program while looking at a book at his computer, and some unused field in your registration program that you can put something in. It's as easy as that. It's not. It can be more complicated, but it doesn't have to be. So, and as we're looking at the new payment models, right now with accountable care organizations and everything, there's a lot more pressure on healthcare entities to work as a collaborative with the community, and to be working with the primary care docs and to help get them into a medical home and so on. The challenge is, I work exclusively at Brackenridge now, and there are good community care clinics in this community. They're actually very excellent, but there's not enough of them, and the waiting list is very, very long. So now I'm getting these indigent patients who come in with earache, and, or whatever, a stub toe, whatever. And historically, I was told, send all of them to community care for follow-up. And then that just made the backlog in the waiting list longer and longer and longer. And so finally, a light bulb went off for me, and I'm like, you know what? This guy with the stub toe, if he has a problem, he can come back and see me in the ER. But the guy who's come in for the 4th time to get his blood pressure medicine refilled, I need to get him into a clinic. And so we started being selective about who we referred to the clinics versus who we just decided to own as an emergency department, and the true episodic care, we felt like we could own that, versus the true primary care, which had to go to a primary care setting. So that really helped us to develop a relationship with community care and with our local medical homes to say, you know what, I'm going to refer you 10% of the number of people I used to refer you, but they're going to all need to get in. So my gift to you is a smaller burden. Your gift to me is working the burden. And let's work that out together. So this program actually helped us to get that going, because now as I'm studying people and I'm seeing who's coming in the ER over and over again, and I'm calling them and saying, you know, explain to me your reality that you think that the emergency department is the best place to get primary care, even though I did 3 years of residency about how to start a dead heart and how to crack a chest in trauma situation. I'm not really expert. You know, my brother just switched from Zestrol to Crestor, and he said, what do you think of that? And I'm like, how am I supposed to know? I have never written a prescription for Crestor. So, you know, trying to get people the best care in the right place, very important. And of course, now we got all this pressure on us to reduce hospital readmissions and to do wellness and prevention programs, and I think this program really does seem to help us with all of that. So my own personal perception is that the High Alert program results in faster care at a lower cost with higher quality and less conflict in the clinical space. That's just what I think. And I'm going to tell you, I had a top 10 list, but then my lecture was too long, so now it's a top 8 list. Besides, Letterman's retired, so I guess I don't have to be exactly the same. But my top 8 reasons why I think this is important. Number 1, it creates a disciplined, standardized process which holds up to Joint Commission legal reviews. We actually have had some patients challenge us when they didn't like the care plan, and it stood up to all of those challenges as well. Because it used to be we were winging it, you know, we just kind of try to remember something about the patient. God, that guy looks familiar. Did I already tell him no 2 weeks ago? I can't think so. Looking at the visit list, so I got somebody referred to me for High Alert because the nurse looked at the visit list and they had 8 visits, okay, in a short time. Okay, that sounds like a lot of visits. So I went and I actually opened the chart and read it. He came in with an infection. We started him on an antibiotic. He came in because the infection was worse and we changed his antibiotic. He came in because his infection was even worse and we lanced the boil that had developed in the meanwhile, but it was an inadequate incision. He came in because the boil reaccumulated. You see where I'm going with this? He's not abusing the ER. We are abusing this man. So, you know, but that's what we had to work with before. We just look at a visit list and we'd see a list of dates and we go, wow, this is a problem, but not realizing it was our problem. So then I called that guy. I'm like, why don't you come in here, let me take care of you myself. I'm going to make like a 4-inch incision in that thing, and we are going to let all the infection out, and you are going to be well. And, you know, that's what we had to do sometimes. This is Dr. Nash, who's now the medical director at Seton Northwest. He gave me this note that he got from a nurse. Patient was here last week, likes Dilaudid, his cousin is in jail. He said, as an emergency physician, I'm supposed to interpret his cousin is in jail relative to the care that he needs today. And you know what? I don't even know why the cousin's in jail. He might be a child molester, in which case he should get Dilaudid because he's suffering from the weight of his inappropriate family. It's easy to do. It's already what we do in most ERs around the country. But the problem is there's no continuity. There's liability with that. We're making judgments based on incomplete information, wasting a lot of resources that way. A much better way is to have this High Alert program with multiple inputs, research on the patient, social work involvement, case management involvement, and then really forming a care plan that works and reevaluating it, modifying it as needed. That takes a lot more work, but it's more of an investment in work than it is a new burden because it saves work on the backside. But it is time consuming. Number 7 reason why I like it, increases physician job satisfaction. I'll show you a little bit of data on that down the road, but I think that's worth the cost of High Alert program. There were some folks who were worried that it would be considered cookbook medicine where the doctor wasn't allowed to make a judgment anymore, but you know what? If I've created a care plan that says no narcotics for this patient and they come in with their tibia sticking out of their leg, they always get a narcotic anyway. My docs are free to make a decision to deviate from the care plan. They just have to document why. And it has to make sense. So if the reason why was because he's my next door neighbor and I felt politically pressured to give him narcotics anyway, I'm probably going to respond to that differently than, you know, his tibia was sticking out of his leg. Number 6 reason, improves the work life of our nurses. Nurses are a rare commodity now. I just was at a meeting before I came here where we talked about the nationwide nursing shortage and how we're approaching that and the current bidding war that's going on for nurses. So if any of you are interested in a career change, nursing now is the time. Definitely anything I can do to make their work easier is important. It involves the ED patient's private physician. And this one, I just love this as much as anything else because we really didn't have a good way to really reinforce our referral patterns. So when a primary doctor has the ability, the patient calls them, I'm having chest pain, which ER should I go to? I would love for them to say Seton or Brackenridge, but we didn't have any way to really glue them to us until we developed the High Alert program, because now when they have complex patients, we're able to work with them to establish a care plan that they create with me, and their patient gets treated the way they want in our environment, which is really very important. I put this in to remind me. So we had a patient, this one happened to be a sickle cell patient, a very, very complex young man. And I'd worked out this triad of healthcare providers for him. He had it's possible for people with sickle cell disease to never have a pain crisis. However, they have to get their blood exchanged once a month. That means we take them into the clinic, we get 10 units of packed cells, we take all of their blood out and give them all donated blood from the donor center, and now there's no sickle cells floating around their bodies, so their cells can't sickle, so they can't have pain. Now, he had already had some damage from his sickle cell disease. He had some bone infarctions and other things that were going to be painful for the rest of his life. And so he needed ongoing pain medicine. And he had some issues with blood pressure and whatnot where he really needed to be with his primary care doctor. But we couldn't get him to be compliant with those things. And all of the primary care providers were very frustrated. And so they came to me and they said, you know, we're trying to do these things, and then he keeps coming in the ER, and you give him narcotics anyway, and it disrupts our care plan. What we want to do as an outpatient, can you fix this? I said, sure. So what I did is I set up a system where only the primary care doctor would write prescriptions. No one else would write prescriptions. He had a pain management doctor. He had to go to that pain management doctor, but the pain management doctor would send a note to the primary care doctor. This is the medicine I want you to prescribe. This is the dose, whatever. That was the leverage to get him to go to primary care. We needed the expertise of the pain management doc to get the meds right, but we needed him to have to go to primary care to get his medicine in order to get him also on his blood pressure medicine, his thyroid, and all that kind of stuff. And the primary care doctor said, I'm only going to write these prescriptions if I confirm with your hematologist that you have had your exchange transfusion this month. So we built a three-legged stool for him to stand on, and it worked beautifully for about 6 months. And then one day, the primary care doctor calls me, and he says, I've got a problem. I'm going to have to fire him as a patient. So that's going to be really disruptive to our care plan. Tell me what's going on. He said, well, one day I was working in the clinic, and I don't know, I set my cell phone down somewhere and it was just gone. And I really didn't think much of it until this patient called to reschedule his appointment and my name came up on the caller ID. So the patient stole his doctor's cell phone and then used that cell phone to call his doctor. Right? All right, I can't argue with you that you should have to keep seeing him as a patient. So we since modified his care plan, but that was a real beautiful project for a little while, and it really was great at tying in all the providers to our, and they weren't referring any of their patients to any other facility once we got this in place. They understood the power of this. Improves the quality of care. We'll go through that a little bit, but having to not do a CT every week forever, that sort of thing, is safer. Improves the speed of care, again, for the same reason. Exposes noncompliance. I looked at this one patient, always came to the hospital on Tuesday for toothache, always had an appointment on Thursday for 18 months. So I said, have you really missed 75 dentist appointments now? I think we have to have a conversation about your compliance with the plan that you tell us is in place. So just the act of reviewing gave us more information than what we had. Now the downside of that is, I'm going to go back, it also exposes our noncompliance. So when I go back and I talk about that cyclical vomiting patient, his care plan was very specific, and it said he'll get this medicine, 20 minutes later he gets this medicine, 20 minutes later he gets this, until he's asleep, and then you let him sleep. Well, you better believe that if it was 23 minutes, he was hitting that call bell. And the nurses would complain to me. They'd say, "Can you tell him?" And I'd say, "No, that's his care plan. You will abide by it. I'm not going to tell him to lighten up. I'm going to tell you to comply with the care plan because that's the promise we made. We're going to do it." So, yeah, so it helps us on both sides of the equation. And it helps us, when I call the patients and I say, "I've referred you to primary care 16 times. Well, yeah, you have, but here's my transportation issue. Here's my child care issue. By the way, I'm homeless. Is today Tuesday or Sunday? I don't really even know. But you want me on October 18th to go to this appointment?" And that's, I don't even know what day tomorrow is. Okay, now I'm starting to figure out our noncompliance and how can we rebuild the system to help you and work on your terms. Decreases conflicts and tension. And I do really strongly believe that this one is true, and I think that's the number one reason. So imagine the doctor at the bedside of a patient who has boundaries put on their care. Doctor says, "I'm very concerned about you. I understand that you're suffering. I am going to do everything I can to relieve your pain. But Dr. Ziebell has told me I am not allowed to give you opiates. So let's talk about all the other options, what else we could do, and I'm going to work with you to relieve your pain if you're willing to let me do that, but this is a line I cannot cross because I can't get fired for you." That's an entirely different conversation than, "No, I am not going to give you narcotics today." And so by putting me in the role of the bad guy helps all the other doctors throughout Seton, and I still suffer every time I go in the room because I'm the one who actually said no. But sometimes I say, "Well, my medical director says I can't give you this," even though I am the medical director. There's a certain amount of politics in the clinical space, I guess. So I wanted to evaluate these reasons, see if they're true. So I did a survey of the staff, and I wanted to find out what was going on. 100% of them believe that high alert makes their job easier. That's physicians. The nurses, 75% of them believe it makes their work easier. Now, the reason I think there's a difference there is because the doctor is here and the nurse is here in the eyes of the patient, and so the doctor says, "I have to comply with the care plan," and the patient says, "Okay, I understand," and then the doctor walks out of the room, and then the nurse walks in, and the patient goes, "What are we going to do about this damn care plan?" And so the nurse still feels a little bit of it, but the majority of them still felt like it made it better. 85% feel that the quality of care is improved. 57% of the nurses felt that way. Improves the speed of care. The doctors thought so. The nurses, a little more than half, thought so. Decreases tension and conflict. The doctors definitely felt this. The nurses not so much, for the reason I just outlined. But my overall, it turns this doctor into George Clooney and I. Because it just organizes everything, makes it much more peaceful, and we know exactly what we're going to do before we even walk in the room of that patient, which is helpful. So this is a document that came out from the advisory board, which is, they give advice to hospitals. That's why they call themselves the advisory board. It says, if you want to reduce unnecessary ED visits, you need to have chronic care management, which I think High Alert program does that. Substance abuse screening, High Alert definitely does that. About 40% of our care plans are related to some sort of control around potentially addictive medicines. Off-site center for the homeless. I already talked about how we've limited the patients we're referring to primary care so that we're more likely to get them in. Primary care liaisons, certainly we do that. I talk to the primary care docs every time we can, and some sort of collaborative clinics, which we've set up. We've got Seton Total Health now and some other collaborative clinics where we really work very closely and side by side in our establishment of how we're going to care for complex patients. So all the things that the advisory board recommended, we're finally doing at Seton now, and they wrote this in 1993. And we are ahead of the curve. So we wanted to study the effectiveness of this program, and what we looked at was 7 hospitals, total of 1,269 patient encounters involving high alert patients. Little bit more likely to be male. They're much more likely to be younger adults than our overall general patient population, just so you know who kind of falls into the high alert category. This is the part I'm kind of rushing through because hospital administrators, they get very excited about this kind of stuff. Other people don't. But basically, if If you want to see the slides later or whatever, I can send them to you and you can study them in detail. That's why they're still here. One thing I did want to point out is that of all the ED visits, the high alert patients are only 2%. And the reason that's really interesting is because those of us who have worked in emergency medicine for any length of time think those are the only patients we see. You know, and even administrators or whatever, all you hear about is inappropriate ER visits and people who just use the ER for primary care and people who are burdened on the system and all of that, and that's all true for 2% of the population. The other 98% are single episode users who don't need any sort of boundaries or controls or special care plans or whatever. So, and this is just looking at the 7 sites, how did it break out? So I said 2% overall, some of them it was more, some of them it was less, but that's what averages mean. And then what did we do? So what we did, we had published a study a few years back about the effect of high alert program on the ED utilization patterns of people with mental illness. We specifically carved out that population. And one of the criticisms of that study, which showed a 40% reduction in ED visits with a matched increase in psychiatric clinic visits. So 1 for 1, they went to a more appropriate level of care, which was just so amazing to me. But what happened is the scientists in the world started talking to us about a phenomenon called regression to the mean. Now what that means is if you are an outlier in any area of life, you will by nature tend to become more normal over time. It's a phenomenon that just happens because it happens. So a great example of that is the guy that I told you about who came in 8 times for the same infection. Once that infection was cured, he quit coming in. So the nature was heavy utilizer, normal utilizer. And so that's called regression to the mean. So we got criticized for that in our first study, that maybe high alert had something to do with this, or maybe those were people who were going to find a psychiatric clinic anyway, and you didn't really change a thing. It's entirely possible. So what we did is we looked at a longer time interval, because by now high alert had been going on for 8 years. And so we said, for any individual, we're going to pick this date as the date that we're studying. We're going to go back to the day that the patient got enrolled in high alert. And whatever gap that was, whatever length of time that was, we're going to look in the equal length of time on the before side. So if somebody had been in high alert for a year, we looked at their use of the ER a year before they got enrolled. If somebody had already been in high alert 3 years, we looked at the 3 years before they got enrolled. And the idea was that the longer you look at the before time, the thought is if they were going to regress to the mean, they would have done that already anyway, so that we could take more credit for what happened. So I just wanted you all to understand that. This kind of shows it graphically what we're talking about. So this patient, we're maybe looking at a year and a year. This patient, we may be looking at 2 years and 2 years, or 18 months and 18 months, whatever. But what we found is that in these patients, in whatever their time interval was before, was a total of 4,526 visits. And for that same summation of after, it was 2,350, 48% reduction in ED visits by getting enrolled in this program. The interesting thing about it is that the people who had lots of visits, their number actually went up. And I think that's like my cyclical vomiting guy. He was also hospital shopping because he never knew where he was going to get his reward today. Once we had a specific care plan, he only went to Seton Northwest until I went to BRAC, and then he only went to BRAC. So you actually, for some of those patients whose need of the ER is legitimate, you'll actually see their visits go up at the expense of the competition. And then for the ones who not so appropriate, they may get reduced by quite a bit. So, and here's what they were coming in for. Backache, headache, nausea and vomiting, shortness of breath. You notice backache before, 6.4% of all of our patients had backache, but 16% of our high alert patients had backache. And then that went down to 12% after they got enrolled. So just some idea of who's in the program. So the majority of them have a pain component of some kind. Top 3 pain-related diagnoses improved in they had a percentage drop. They had less visits related to their painful diagnosis. And only 4 out of the top 10 diagnoses matched the general patient population. And so, and then we thought maybe we're going to save a bunch of money on tests and whatnot. And this one really interested me. And for like a week, I was really disappointed in this slide. Because I thought, surely, once we identify that a person is coming in all the time for belly pain, they don't need a CAT scan at every visit, we're going to see the number of CAT scans dramatically drop off. We're going to see the number of lab tests dramatically drop off. Then I thought about it, and I thought, you know what? This is actually good. Because what this is telling me is that when the patient comes in, even though their wristband says 33, the doctor is not just dismissing them out of hand. If they're coming in, they're getting evaluated, they're getting tested, they're getting medicines and whatnot, and that's probably a good thing in the end, that we're not just, because, you know, part of it is the cried wolf phenomenon. Are you going to cry wolf so many times, and then when you actually have your heart attack, we're going to let you die because we've just said, no, you never have a heart attack, we're just not even going to check today? That's not what was happening. So I was actually kind of pleased by that. And remember, we did have a 48% reduction in the number of visits. So even if their per visit use of CT, X-ray, and lab stayed the same, overall we still saw a 48% reduction in imaging studies and diagnostic testing. So it was good. And here's what it looked like before and after for that patient population. Disposition, the ones who got admitted still got admitted. The ones who got discharged still got discharged. The ones who got transferred still got transferred. So it really didn't, again, it's not prejudicing our care of the patient. We're treating them the way we would treat them. And the length of visit was unchanged. We thought it might shorten it because we would be doing less testing, but we found out we're not doing less testing, so we didn't shorten the length of visit, which is okay. Another interesting thing, for in case there's any money people involved in this, is that our payer mix, that's the percentage of, you know, I pay cash because I'm wealthy, I have great insurance, I have moderate insurance, I have crappy insurance, I have no insurance. The payer mix at the time of enrollment in High Alert was 11% worse than our overall patient population. And then in the after period, they had the same payer mix as our general patient population. What that means is that we were successful in our case management of these people of getting them signed up for things that they should qualify for. And we turned them from patients without alternatives into patients with alternatives, which I thought was a really, really cool side effect of the thing. So before, they were much more likely to be charity care or maybe Medicaid, 7% more likely to have to pay out of pocket for everything, 15% less likely to have commercial insurance. And then after, they turned into our regular patients. So it's just very, very cool thing. So again, 48% reduction in ED visits, while there was a 7.1% increase in the number of visits overall out of the general population. So that just puts that 48% in perspective, I think. Soft findings, decreased variability. Patients appreciate the fact that you know them when they come in. I think I've found that to be very true myself clinically. There are patients who come in who demand that we follow their care plan. They're very happy that we have one. I can't tell you what the impact on satisfaction scores is because, for those of you who aren't in this business, this is how satisfaction scores work in healthcare. Brackenridge ER sees 220 patients a day, roughly. I have 38 physicians who work for me. The hospital surveys 30 patients a month. So for me to carve out any impact of high alert versus non-high alert out of 30 patients a month and aggregate it to have any kind of a meaningful impact, that would be a study that would take me 10 years, and by then it already wouldn't apply because all of healthcare is going to be different 10 years from now than it is now. But again, the hard findings we just went over. And then these are just a couple of other examples. And again, I left the slides in case any of you want the slides after, but we studied this again and again and again. My group staffs 25 hospitals throughout Texas, so Seton is not our only client. And so we've implemented this at Christus and New Braunfels. We've implemented this at Harker Heights. We've implemented this in Bryan College Station. And so these are just examples of other places where we put it in place. And again, very similar, 40 to 50% reductions in ED utilization everywhere that we put this program in place. This one is more related to costs. Just to show you, these are individual patients. So this was a case manager who just decided to pick a handful of individual patients and look at their costs before and after enrollment. Before is blue, after is yellow. To give you an idea, that's the cumulative total. It's a little misleading because this is 9 months and this is 4 months, but 4 months becomes 9 months, it's still smaller. So if we annualize it out, that's what it would look like. It would still be about a 60% reduction in cost per patient. Our estimate at Seton was that every patient in high alerts saves the network $8,000 a year. And right now we have somewhere around 8,000 patients in high alerts, so that math adds up pretty nicely. Third example, again, far fewer visits, same kind of data. Now the last time I gave this talk was in Houston to a group a lot like this. It was a hodgepodge group made up of community leaders there, and it was the police, the fire department, EMS, the local mental health authority, some outpatient community care clinics, and I forget who else was in the room, but it was really kind of a cool group to talk to. Nobody from the hospitals was there. That question and answer session lasted 2.5 hours. So that's my challenge to y'all. Feel free to ask me.
If you have any questions, I'll bring you the mic. Anybody?
And also on the WebEx, if you have questions, you can type them in, and Josh will read them to us.
I'll start with one. How long from the time that you started the program until you felt like it was fully assimilated throughout the hospital? Because it really has to go beyond the ED.
So that probably took a good 8 years. We spread it across all the emergency departments pretty effectively, pretty fast, but the real issue was that, especially at first, I didn't know anything about how to share an access database, so at first it was really this notebook. When we make a new care plan, and then we would have to make 8 copies of it and run it out to all 8 of our ERs, and then to think about doing that on every inpatient unit and whatnot was just overwhelming. So until we were able to really convince the network that there was value in this, and get them to dedicate us some programming so that we could use Active Directory as our way of accessing the database, and we could create a database that allowed specific user profiles based on Active Directory so that we could keep track of who's allowed to write care plans, who's just allowed to read them, who's allowed to put stuff in but other people can't see it, and who's not allowed to do anything other than read it. We had to sort of develop all that, and that took about 8 years. And I will tell you that, honestly, it's still not as spread to the inpatient towers as I would like. There are some that get it more than others. I think it's been pretty well incorporated at Brackenridge now, but less so at the smaller hospitals where they don't feel like they have as many problem patients. But realistically, it took probably about 8 years to get to a good state where I felt good about it.
Yes, could you repeat or say more about the relation of your medical director record to the patient record in general, the relation to HIPAA, and some of the fields that you allow high-level staff to see and not other people to see? Can the patient ultimately get that or demand that?
We have been challenged on that in the past, to what extent the patient can demand it. And so far where we've successfully stood is that they can and should have access to the active care plan as it exists on the day that they ask for it. And so background notes and things like that are for our own internal use are for our own internal use, and many of them have not, their ideas that got shared in the database that were never implemented, or discussions and dialogues between me and others who helped me support the program. And so we've held that as internal work product and not as something that we can or should share, and that has held up so far, which is good. The way that our database works, I know there's some technical people in the room, and I will tell you that HCA copied our program and they did it better. Because they came and they talked to us and they said, now that you have it, what do you wish it could do? And we told them our wish list, and they built it based off our wish list. What it does is there are things that anybody can put things in. So one way that people can refer to me is they can enter a patient in the program, and then they can say, I have a lot of concerns about this patient because of X, Y, and Z, or this patient seems to be failing outpatient management, can you help him, or whatever. And then they get a drop-down list, it's called a referral list, and it refers to me. So the next time I log onto the database, the first page that opens is a list of all my referrals. And then I can read those, and I can respond to them in whatever way I feel is appropriate. And I can re-refer to somebody else. So if a nurse puts something in and refers it to me, I may refer it to my high alert coordinator and say, can you investigate this a little further and send me a summary or whatnot. And then we communicate in the software that way. And it's very possible that no one but us will ever be able to see that. But next to every entry, there's a little checkbox, and if a medical director or director of nursing puts a check in that checkbox, then it becomes available for public viewing. Not public as in non-HIPAA, but public as in I've logged on with my Active Directory password as a healthcare provider, and now I can see that information. So they won't see everything that's in there, but they will see the things that that a medical director or director of nursing have deemed, yes, this is something that the people caring for the patient should be able to see. And every once in a while it happens where a nurse will send me something really inflammatory or a social worker will or something, and I just don't feel like it will ever be appropriate. It's relevant to me making a decision, but it's not ever appropriate to it's a little too inflammatory to put that in where everybody's going to read it. So, and good examples of that are typically the 1111s, where a nurse has just been assaulted by a patient and they write something with cuss words in it, and there's a lot of anger. I just got beaten up by this patient, and you need to throw the book at this asshole or whatever. And I will gently modify that to say, records indicate patient has assaulted a healthcare worker in the clinical space. And that's what I put in the record. And I may take out a lot of the details about how that assault occurred, or, punched me 6 times in the face and stomped on my toe. They don't need to know all that. What they need to know is that this patient is capable of assault. And so that's what I put in there, because I think the more you inflame the patient, the information about the patient, then the more tense that next meeting is. Whereas right now, it's sort of, we know a lot of these are people come in drunk and they're a little combative or whatever. That doesn't mean they're going to be combative every time. And so we want to always approach them with dignity and respect. We have a security approach that we take with them. So anybody who's a high alert level 1 gets their possession searched for weapons and some of that sort of stuff. They get wanded with a metal detecting wand. That's all part of our policy, and it happens every time. But we try not to do it with the assumption that you're going to assault us every time you come in. It's more about, we're aware that this happened one time, and we want to keep the conflict between you and us to a minimum, so we're just going to make sure that you're not armed and we're not armed and everybody's happy. And that's how that works. Yes, ma'am. Mm-hmm.
You talked about the referrals can come from anyone for the high alert program, but how is the referral actually made? Can you give us an example? How will we make and who would make it?
So I mentioned one example, which is somebody logs onto the software and puts a referral in themselves. And most, I would say 90% of the employees at Seton don't know how to do that, and I wouldn't expect them to. So really what happens most of the time is there's an email referral. So at Seton, our high alert coordinator, interesting side story, Kim Deere is our high alert coordinator. She was the night shift unit clerk working that day. Got so excited by the potential for this that she actually went back to school and became a licensed chemical dependency counselor. And she now coordinates the program for the entire Seton healthcare family. And I think she's going to take on Waco soon as well. So, but most typically it's an email referral or a note dropped in my mailbox at the office or something like that. It's really, we're not dramatically concerned with how we receive the referral. At any of the hospitals, the ED medical director is a great source. So it's not just me, it's Dr. Nash, Dr. Hidari, at any of the sites, we've got a medical director. He can take that for you. Any of the social workers know how to make a referral, so people can talk to the social workers and have the social workers refer it in. And really, it's just getting that information to the site social worker, the site case manager, Kim Deere, myself, the site medical director. any of those can take that on, or the director of nursing. Although, to my surprise, the directors of nursing have not been involved in this as I thought they might be. I think mainly because the docs embrace it so much that we just do that work and save them the bandwidth. Yes. So I get a lot of referrals. So the question was for a particular situation that she has because she works for Seton Total Health. I get a lot of referrals from Seton Total Health, and it's not uncommon for someone from Seton Total Health to write a very specific care plan and then email that to Kim, and we just put that in verbatim as long as, I mean, if I look at it and I think there's a medical issue with it, I might call Dr. Eaton or somebody to talk about it. But as long as it looks medically appropriate to me, I just put it in verbatim, and I don't touch those. Yes.
Hi, I'm interested in the interoperability aspects, and also as like a personal health record that these people could, if they can't carry it with them, at least access it. Let's say they are out of your area. Do you confine this? Does this care plan, is it an intranet kind of thing, or can it be accessed externally?
It is on the intranet, so the way to access it externally is only if you have the ability to VPN in or through Citrix or something like that. Now, for other entities to look in, I'm going to talk about that in a couple of different ways. So for Seton specifically, the answer is no, that their database exists on their intranet, and you have to essentially be inside or virtually inside in order to access it. We do share with the rest of the community. So HCA, I mentioned, has this as well. So St. David's, South Austin, those hospitals have this as well. And the way that we interact with them is once a week we have a citywide high alert meeting. And what we do is we leverage EMS. So if I have a patient that I think doesn't just need a Seton plan, but they need a community-wide plan, I look in their medical record, and the question is, has this patient ever come in via EMS? Yes, here they came in by EMS. Now I know that we have a patient in common. HIPAA allows us to talk freely about that patient around the issues that we were caring for them commonly for. Since the issue is frequent ED utilization, I can talk to them about that. They can talk to me about that. And as a part of that conversation, I can ask them, have you ever taken that patient to St. David's? Yes, I have. Now we know that we can talk freely. And then we sit down at the meeting and we look at, usually by then they've already got the patient in their high alert, we've got them in our high alert, and we look at them and we compare and we merge them into one citywide care plan.
I'm thinking more about as a patient who moves out of the area who may want to be able to log on to the personal health record aspect of this. Say I end up in an ER. Can I log on and say, look, here's my care plan? Is that available to the client?
It's not, because it's not part of the medical record. So it's a separate database, and that's how it works here. In HCA, it's actually built into Meditech. And so they built it as, instead of a separate database, they built it as a specific document that gets built in their documents folder. And so that would flow through. But the problem, from my mind, the challenge with that is the things that you don't want to make public and this ability to refer. I mean, our database has a lot of functionality in it. And theirs does too. They have a separate database, but their database creates a product that gets loaded as a document into the medical record. Ours stays separate. Oh, goodness. So the question is, why doesn't Cerner have something like that? The answer is because every single time I give Cerner a good idea, they decide how far down the list that needs to go. So they're just, Dr. Tinsman explained it to me this way one time. He was our head of IS at Seton and until he retired. And he explained that any major software program, whether it's Microsoft Office or Quicken or whatever, takes 20 to 25 years to mature. And Cerner right now is a fussy teenager. And so I just kind of put that perspective on that 10 years from now it's going to be a great product, and I just got to have the patience to get there. We have had conversations with them about doing this, and they're kind of interested but not ready. We've also had conversations about working with an external vendor to talk about doing some sort of a bolt-on. But IT sphincters tighten whenever you talk about bolting anything on to anything. And so those conversations really don't go very far. Thank you. Thank you. No, I appreciate the opportunity to talk.
Thank you. And don't forget to fill out your evaluation forms. And again, thank you to our chapter sponsors. If you're interested, let me know. And Dr. Ziebell will be around for maybe a few more minutes if you have questions one-on-one. But thanks again.